all the fluoro machines on the patient's right. This is mostly because the fluoro machines block any kind of mobility of the left hand. Leaving good space for the right hand to be able to access instruments from the Mayo and work. Now, the first step here, we're going to use fluoro to create drawings on the skin to isolate where the proper incision location is. So we're basically using some geometry here. We're going to mark a center line just to confirm everything is exactly, equal. And now we're marking this lateral line at the end plate. The intersection of those two lines on the surface is going to give an indicator of where the center of the disc is. Now going to the lateral, we're marking just about to the center of the disc space to find the lordotic inclination of the disc. We're going to mark that on the skin up and over the flank. And then we're going to take the wire, lay it across the patient's back, and figure out a rough estimate of the depth to the center of the disc. We're going to mark that from the center line out laterally. So that distance from the midline out laterally is going to tell us how far off midline to make the incision. The lordotic angle is going to show us a line on which to make the incision, and the intersection in the AP of those two lines is going to give us our target for the center of the disc. Now what's happening is that Dr. Abbasi is going to collect bone marrow aspirate from the superior contralateral vertebral body pedicle. Using a Jamshidi to cannulate the pedicle, he'll collect 5 Cs of bone marrow aspirate from that location, and then he'll place his guide wire to be used eventually for placing the pedicle screw. That bone marrow aspirate is going to be used to hydrate a tricalcium phosphate sponge, and that is going to be used as our biologic for this procedure. Since there is no bone being collected, there's no allograft bone to place into the cage, we're using a synthetic bone marrow aspirate and tricalcium phosphate. The tricalcium phosphate is specifically on a collagen sponge, and it is infused with hydroxyapatite crystals, which gives it some visibility on the flora. Now in the AP and lateral images, you can see the neuromonitoring probe is being introduced. He's targeting the inferior pedicle. He's going to put the tip of the neuromonitoring probe into the lateral foramen, inside of Camden's triangle. Touching on the inferior pedicle is going to ensure that there's no nerve inferior to his location. So after he touches the inferior pedicle, he's going to work his way down around into the foramen, get a neuromonitoring signal of 3 to 5 milliamps, remove the probe, introduce a guide wire. It's a 1.4 millimeter guide wire. It's quite flexible. Take out the neuromonitoring probe sheath. That's a concentric sheath that was on the probe. Now he's introducing an 8 millimeter dilator. Since the guide wire is quite flexible, the dilator is very rigid. Any adjustments can be done with the dilator to perfect the trajectory. His goal is to be in the center of the disc space under the sponge process and 50% across, and then to go a little bit further after these established the right trajectory. Now it's the access portal is being introduced. It's a 10 millimeter sleeve. The dilator will come out, and that'll leave an 8 millimeter working channel through the 10 millimeter portal into the center of the disc to be used for discectomy. The first instrument to be used in discectomy is a drill. You can see he's got a drill in there, twisting it around. The flutes of the drill are very effective at gathering the nucleus. This first pass is just to make a cavity for the next instruments to come in. The next instrument is an expanding paddle shaper. It enters at 6 millimeters height, expands in 1 millimeter increments, has a maximum of 16 millimeters. As he's expanding it, he's going to be able to use that device to measure the height of the end plates. Now he's going pituitary rongeur to be able to capture the fragments that were created by rotating the paddle shaver. This instrument that's being prepared is a flexible ring curette. It's a nitinol blade, super elastic. It goes in a collapsed position. The sleeve is open to deploy and expose the blade. The blade is used to scrape. The blade is capable of expanding to 13 millimeters off center line, so rotating the blade at a full expansion is not advised. The blade's intended to be a push-pull, like a ring curette, to be used in a traditional T-lift. Switching back to the pituitary rongeur to capture any fragments that were cut loose. The next instrument is an articulating curette. It functions similar to a cup curette in a traditional T-lift, but it has a flat surface. So it goes in through the portal, is articulated to connect with the end plate, and then used back and forth, reciprocal scraping motion. That device gives excellent tactile feedback to know if you've gone through the cartilaginous surface and that you're actually working on the corporal end plate. Pituitary rongeurs to capture fragments. With the articulating curette. What you can't see in the AP view here is that you can change the angulation slightly of the access portal to be able to create a fan-shaped triangular surface where you're working. So now we've already placed the graft material that was the hydrated tricalcium phosphate, put in a guide wire, remove the access portal, and now the implant is being delivered over that guide wire. The implant and the introducer are cannulated, much the way a pedicle screw would be, and that gives us our trajectory down into the disc space. There is no access portal being used at this time. The implant is going through the pathway that was already opened by the access portal. Wire is being removed so that we can place the implant into the center of the disc space. As this was a rather tall implant, Dr. Abbasi placed it at the 9 millimeter side towards the end plates, and now he's rotating it so that the taller part of the inner body is against the end plates. So this is a in situ rotation that allows you to introduce the smaller height and then expand to the taller. Okay, now the inner body portion of the procedure is complete. We'll be moving on to pedicle screws. We're using a 10 gauge Jamshidi here. This is just a more rigid Jamshidi. The traditional systems usually use an 11 gauge. This just gives us a little more rigidity. To require additional bone marrow aspirate to use in the graft material being delivered to the posterolateral gutters, we would collect that additional bone marrow aspirate from a different location. So the JMCDs being placed into the L5 vertebra would be used to collect more bone marrow aspirate if needed. For one little case, the initial draw and the initial package of TCP is usually sufficient. The reason we have additional TCP is to do a posterolateral fusion. You can see Dr. Abbasi placing a dilator now just to open the fascia. And on the back table, they're preparing a special dilator and decorticating device. This device is placed over the guide wire that's already in place for the pedicle screw. The decortication device is only used at the inferior level. We don't use it at the superior level because we don't want to disrupt the facet joint at the adjacent superior level. So we'll place this over the guide wire at the inferior L5 level. Special tapered dilator puts the center of the decortication sleeve over the facet joint. And that decortication sleeve gives a graft delivery pathway, and then we're tamping that graft down and removing the decorticator to address the opposite side. Again, the offset tapered tip of the dilator places the center over the facet joint, decorticating on the surface of the facet joint, placing graft material. And now we're going to place the pedicle screws on top of the graft material. At this point, you see the AP fluoro machine has been removed. After the trajectory is done and the guide wires are in place, only the lateral is required to see the depth of advancement of the pedicle screw. The AP machine is not required. These pedicle screws have a 5-inch break-off tower on them. The tower is machined into the tulip, and then at the end of the procedure, there's a specific groove machined into them to fracture, which leaves the construct in place but removes the tower. All 4 pedicles screws are in place. We're going to use a couple of instruments to orient the tulips so that the rod can pass smoothly between them. And then we'll also measure the length of the rod. There's a special caliper that will tell us the length of rod to be needed. So this is the orientation instrument to just align the slots in the towers. Now a caliper for measuring the length of rod required. While waiting for the rod to be prepared, we're doing some subdural injections. Right angled rod inserter. This is generally used at one level cases. There's a different arced rod inserter that is generally used at two level and longer cases. The pedicle screws have 25 millimeters of rod reduction. So the set screw comes in, connects with the threads, and then can push the rod down into its final location. You want to get the rod as far inferior as possible so you're not fighting against as much of the musculature. But then use the guide or use the set screw to force the rod into its final location. So the rod is seated in its final location. There's an instrument to remove the connection, retaining the rod inserter. Go with our final tightening torque limiting device. So the pedicle screws, rods, and cap screws are complete on the patient's right. Now delivery of the rod on the left side. And now we've finished tightening the cap screws on the left side. Next step is to cut the tabs that join the left and right hand sides of the tower. That makes them each break independently instead of requiring double the force to break them. We're using opposing breaking tools so that we're counteracting the force required to break off the tabs. Machine for a final post-opsy image here. So in essence, the final closure here, we're covering up 4 percutaneous wounds for the pedicle screws and 1 percutaneous for the interbody. So we have a total of 5 small incisions, probably no more than 10 to 15 millimeters each. So for this procedure, the screws that were used, the pedicle screws, were 7.5 diameter by 50 length. The rod was 50 millimeters long on both sides. The cage placed is 9.5 wide by 33 millimeters long by 13 millimeters high. And as we placed that, it went in on the 9.5 wide against the end plates and was rotated to the 13 wide by 13 high for its final location.